All right, we can get started. So my name is Audrey Hazel Baker. I'm a behavioral health consultant with the Michigan Opioid Collaborative. We host a monthly webinar, and we're excited to have Dr. Avinash Hasanagar here today. Dr. Hasanagar, he's an assistant professor in the Department of Psychiatry and a staff psychiatrist at the Ann Arbor VA. He completed his medical training at St. John's Medical College in India and his residency and fellowship at Western Psychiatric Institute and Clinic at the University of Pittsburgh. He joined the faculty in the Department of Psychiatry at Michigan Medicine in 2010 as a staff physician in the Substance Use Disorder Intensive Outpatient Program at the Ann Arbor VA, where he manages patients with moderate to severe substance use disorders and provides medication for opioid use disorder treatment, also known as MOUD. He has authored scientific papers on substance use disorders and MOUD. He currently serves as the medical director of the Substance Use Disorder Program, and he's on the Pain Management Committee through the Ann Arbor VA healthcare system. So before we get started, I just wanted to go over a few items. Please introduce yourself in the chat box so we know who's here. If you want to be included in our marketing list and be notified of any future webinars, please just include your email in your introduction as well. We will send you a follow-up email within the next week of the slides that are presented today. I will send the CME code shortly in the chat box for anyone who logs on late, so that'll still be available for you. And lastly, please keep your audio and video muted while Dr. Hasanagar is presenting. Feel free to answer any questions you may have in the chat box, as we should have about 15 minutes at the end for any Q&A. So with that, I will turn it over to Dr. Hasanagar. Thank you.
Hi, I hope you can hear me. I'm happy to be here. Good afternoon, everybody. I'm going to spend about 45 minutes going over the basics of drug screening. I'm hoping to give you some practical pointers towards using drug screening. A disclaimer, I work entirely for the VA system. I don't deal with insurances, so I'm not the best resource for costs and insurance reimbursement, but I'm hoping that I can go over the general principles of drug screening and what would be useful for your clinical practice. So with that, I have no conflicts. Nothing that I'm saying today I make profit off of. So my objective today is to familiarize all of you with the commonly available drug screening techniques, help you understand and interpret a urine drug screen, and review some testing strategies for some common drugs that you might encounter in your practice. So I'll start off with a quiz. You know, oxycodone will always show up positive in a urine drug screen, true or false? A urine with a creatinine level of 15 milligrams per deciliter is considered okay, dilute, concentrated. Choose one of them. Alcohol used in the last 48 to 72 hours can be detected by what test? And false positives in drug screening can be common due to what? I hope by the end of this talk, you would have a good idea for all these questions. I'm also going to go over 4 cases to set those as examples that we could kind of maybe think of cases as they come in your clinical practice. So the first case is of a 60-year-old male patient on liver transplant list who's poorly engaging with outpatient substance use treatment program and states he does not need any substance use disorders treatment, as he has been sober and has consistently provided negative urine drug screens and breathalyzers. His GI and transplant team report poor engagement in care, and they are concerned for continued alcohol use. What lab test would help confirm your clinical suspicion? A 38-year-old male with a 15-year history of alcohol use, recent DUI, who's court ordered to be in treatment, currently engaged in an intensive outpatient program, appears to be participating well, However, the social worker informs you of reports from his peers that he may have been drinking alcohol over the weekend. What test would help in this situation? A 46-year-old female with history of cannabis use who agrees to abstain from cannabis to continue with her opioid prescription for chronic pain. The nurse brings her to the doctor's office after reviewing her positive cannabis on the urine drug screen. She's very distressed and says she has been clean ever since you and she had a discussion 4 to 5 weeks ago. And she does not understand why her UDS is positive for cannabis and requests you to retest her. How do you proceed? And lastly, a 43-year-old female with opioid use disorder on Suboxone, who's been attending regular monthly follow-up but has missed her last appointment with you and asked for refill over the phone. Today, she seems somewhat somnolent during your appointment, states that it's because she's been working the night shift for the last 3 days. Her UDS has been negative for the past 3 months. What could be the next steps? What labs would you consider ordering for the patients with opioid use disorder on Suboxone maintenance? So getting into a little bit of history, drug testing has been occurring since early 1900s at workplace. In the Vietnam era, there was significant substance use by military personnel. And it was at this period that DoD started thinking about more rigorous drug testing. And by early 80s, military had established some form of drug testing in the services. In 1986, President Ronald Reagan issued an executive order to create a drug-free work environment, and subsequently DHHS developed some guidelines for drug testing, and it became mandatory for federal workers to get drug tested with the program in 1988. And in 1989, the US Department of Transportation issued regulations requiring the testing of nearly 7 million private sector transportation workers in industries regulated by the Department of Transportation. So we can think of drug testing in 3 main categories. The first one is federally regulated for selected federal employees, including military personnel and those in safety-sensitive position, including me. I work for a federal agency, so I get tested in this manner. The second is federally regulated for non-federal employees in safety-sensitive operations like airline and railroad personnel, commercial truckers, school bus drivers, etc. And lastly, non-regulated for non-federal employees. These are the rest of the employers who are using drug testing for their employees. So commercial truck drivers, railroad employees, and airline personnel make up the largest group of individuals being drug tested. You'll hear common terms when you're looking up information about drug testing. One of them being NIDA-5 or SAMHSA-5 or DHHS-5 or the federal 5. They refer to 5 commonly tested drugs, which are opiates, marijuana, cocaine, amphetamines, and PCP. MRO is a medical review officer. DOT certified lab, which is the same as a SAMHSA certified lab. POC testing, which is point of care testing, which is testing right in your office. A test matrix is the biological specimen which is used for testing for the presence of drugs or metabolites. And a drug test panel is a list or a menu of options of drugs or drug classes that can be tested for in a given specimen. So what are the goals of drug testing? Most commonly, simply is objective identification of substance use or abuse. In psychiatry, we use it for differential diagnosis because a lot of symptoms can present because of psychiatric symptoms can present in the context of substance use. It can be used for treatment initiation, such as in Suboxone. And then for monitoring purposes, for substance use and accountability. It can also be used for documentation of recovery, and it's commonly used for advocacy for patients. It's used in forensic setting for parole and probation, and very commonly, most commonly as a deterrent in workplace, such as in among healthcare professionals, in sports, and for public safety. Um, I just want to go back to a little bit to understanding the epidemiological terms of sensitivity and specificity, because these are very important for drug testing. So sensitivity is the proportion of patients with disease who test positive. So those who have the disease and truly test and test positive for it, those are the true positives. And specificity is about detecting the true negatives. That is the proportion of patients without disease who test negatives. Proportion of patients without the disease who test negative. And then we worry about false positive and false negatives in a clinical situation. So what are the qualities of a drug test? We're looking for a drug test which is highly sensitive, which is highly specific, which can help in confirmation. We want it to be of low cost so that we can utilize in large numbers. We want the results to come back rapidly so that our interventions can be timely, and one that can adapt to different settings. Now, this would be an ideal quality of a drug test. Now, unfortunately, each type of test that we use is good on some of these points while not so good on other points. So we'll go over some of the commonly used methods for testing. So the commonly used methods are thin layer chromatography, enzyme immunoassays such as ELISA, um, gas liquid chromatography, mass spectroscopy, and gas chromatography, mass spectroscopy, which is what you'll hear a lot as well, also known as GCMS. So immunoassays, these are the most common methods that are used for initial screening processes. They simply involve an antibody that detects the presence of specific drugs or metabolites. They are always considered as presumptive because these antibodies may or may not react in some situations, and they may cross-react with something which is structurally similar to the drug that we're looking for. So it's more prone to false positive and negative results. GCMS, which is gas chromatography mass spectroscopy, is considered the standard for confirmatory tests because each drug gives out a specific spectra after the chromatography. And so you can identify a specific drug and you can actually get quantitative information from this. So, but it is more time consuming and it requires a high level of expertise to perform. So not all labs are able to perform this. So just to compare this, ELISA or immunoassay, which is what we use commonly, has moderate to high sensitivity. Specificity is about moderate, and the cost is relatively low, about $5 to $10 per test. On-site testing, again, moderate to high sensitivity, moderate to high specificity. Cost is low to medium. While the gas chromatography mass spectroscopy, which you use for confirmatory testing, is highly sensitive, highly specific. It's very accurate, but it takes days for the results to come back, and it has substantive costs. So we can't be using GCMS for routine care, routine testing for all patients. Point of care testing, which is something that we can use in our offices, is performed on site. It's used for random testing of patients where we don't necessarily have access to labs. This could be done in our own labs. Generally involve collecting urines, and generally these have multiple panels, and each panel shows up positive for a specific drug. You look at the panel to see if it lights up for the presence or absence of a colored zone. Different body fluids or specimens can be used: urine, breath, blood, saliva, hair, nail, and sweat. Most commonly, we use urine because it's easy, and I will get into why urine also is a good specimen because of what it allows us to test. Breath test is most commonly used for alcohol. Most of you must be aware of. Breathalyzers is used in clinical setting, it's used in the roadside setting by the police, and it's used in workplaces as well. So it is very convenient way, and it's very accurate in terms of showing corresponding blood drug level. It's most commonly used for alcohol. There's some research going on with cannabis as well. Um, However, because of COVID, there is it is being less utilized in this particular phase. While COVID is active because of high risk of infection transmission. So in our hospital, we are currently not utilizing breathalyzers at all. It's on a pause until this COVID period passes. Saliva is pretty easy to obtain. It's also easier for observation. So for someone in where we have concerns for urine dilution or manipulation, you can actually observe them giving a spit saliva sample. The level, the accuracy is pretty similar to plasma. It's good for generally water-soluble drugs and conjugated drugs. And there is some increasing interest to utilize this in this COVID period over breathalyzers, especially because some of these can be obtained from home. Sweat is commonly utilized in probation settings. This involves a drug being excreted out in sweat, and usually this sweat is absorbed and concentrated in a cellulose patch. It's less invasive. This cram ankle bracelet is a really good example of that. And the results are uploaded regularly via a modem and monitored by a private company, which sends the information out to the party that is interested in this. And lastly, hair usually accumulates breakdown of our metabolism over time. So drugs which are in hair deteriorate after about 3 months. So you get a 3-month window for detecting drugs, and given the slow growth of hair, you can about 1 centimeter per month, you can get about a centimeter sample, and you'll get a good estimation of drug use for the past month. So it's used a lot in the workplace and forensic setting, not so much in regular clinical settings. And nails are very similar to hair. So what are the key steps in drug testing? One is proper specimen collection. I think without this, if you don't collect your sample well, and if samples are contaminated, if you don't collect adequate amount of sample, if there is any problems with this, you're not going to get accurate drug testing results. The next is initiation of chain of custody. So ensuring that there is no tampering with that sample is going to be really critical. And finally, the analysis of a specimen, which requires a good lab to be able to do some of the testing you want. Specimen collection can be voluntary versus involuntary. In a lot of legal and forensic situations, it's involuntary. And also, whether testing is done unobserved, which is majority of testing, versus observed, which in some clinical settings you may want observed testing done, and that brings on its own privacy considerations as well. So moving on to the actual specimen validation. So I'm going to stick to urine here because that's the most commonly utilized method. You want to make sure the urine that you're getting is really the patient's urine sample, and it's a human specimen. So we look at things like color, temperature at the point of care. We look at when you send it to the lab will look at the pH, creatinine. Creatinine is a product of muscle breakdown, and so it's a normal, as most of you would be aware, it's most urine samples will report a creatinine. This is a really good indicator of dilution, and I use it very commonly. If the urine creatinine is less than 20 milligrams per deciliter, the urine sample is considered dilute by most labs. And if it's less than 5 milligram per deciliter, then it's not considered human sample. I generally watch the creatinine very closely because it's very difficult for a patient to consistently give a urine sample with the same creatinine level. Often when they give you a tampered or a urine sample that is not their own, you will see this urine creatinine hit the same number or around the same number by a range of 10 or 15 milligrams per deciliter each time. Then you have to be a little more cautious, because it's very difficult for someone to give you urine samples each time in that range. And I look at that, and if the urine samples are consistently staying below 30 to 40 milligrams per deciliter, I would be concerned there as well, because that may be a sign of an attempted dilution. So I would watch out for that. Specific gravity between 1.0 and 1.030 is considered normal range, and labs will tell you if they are not within that range, and they might not proceed with further testing if it seems too dilute. So what are the characteristics of a urine specimen? The temperature within 4 minutes of voiding is between 90 to 100 degrees Fahrenheit. The pH is between 4.5 to 8. The urine creatinine is more than 20 milligrams per deciliter. Specific gravity is more than 1.003. I mean, the things to look for is if patients are giving you extremely cold urine or extremely warm urine. I mean, those are signs that the urine sample may have been tampered with. So you have to be cautious about that particular urine sample. So some common tricks that people use to escape detection. There are various commercially available products that you can all you have to do is drop a couple of drops of that product into the urine sample. They use household chemicals. People use synthetic urine sometimes, and it's commercially available for people to get that. And the most common method is urine dilution. There are various commercially available products. Like I said, people might use bleach, salt, vinegar, detergents, eye drops to kind of mask a drug screen. And this is a Visionator, which is a commercially available kit, which is used to deceive people even during observed drug testing. So that's something where patients bring in their own urine sample from outside and make it seem like it's a real their own sample. So that's something that we have heard of. I have personally not seen it, but it's not uncommon for patients to use this. The next thing I want to talk about is window of detection. So this is critical in terms of drug testing. If you don't test it at the right period, then you're not likely going to detect the drug in the sample that is provided to you. So these are the factors that are important to consider: how frequently a person has been using it and how long have they been using it for. Drugs that are used on a long period of time tend to accumulate versus drugs that are used intermittently. How much is taken, how much is ingested, and the rate at which that substance is metabolized. So it might also involve some pharmacogenomic abnormalities and the cytochrome enzyme system, which are breaking down that drug. You want to think about the physical condition of the patient and if the drug is lipid soluble. So if someone who's obese is using a lipid soluble drug, that drug will stay in the system for a really long time despite their abstinence. So you have to factor that in. What is the cutoff concentration of the test? Your lab may be using different concentration from my lab. So the urine may show up positive in one situation and not another. So that's something, again, that you need to consider. Generally, you can see that breath and blood have detection windows which are usually between minutes to hours, while urine is between minutes and hours to days, weeks, and months. While that of hair is usually more prolonged after days and months and maybe even years. So urine gives us this really nice window of detecting things from a few minutes to a few weeks after a person has used substances. And that's why it's the most commonly utilized method for drug testing. Detection time, again, something like marijuana with a single use, you can detect up to 3 days, but chronic heavy user, you can see it up to more than 4 to 6 weeks. You know, I've seen patients have their urine positive up to 8 weeks sometimes after their last urine, after their last use of marijuana. Similarly, benzodiazepines, if it's a long-acting versus a short-acting agent, the duration of that lasting in the system can vary, and therefore the window of detection changes. Generally, for opiates, we see for most opiates, it's about 48 to 72 hours. So that gives us a good estimate, at least for most opioids, that they would be detected in the 48 to 72 hour window. Methadone may stay in the urine for a little longer. These are the federal cutoffs. And this is commonly used by most labs. You'll see that the immuno levels of cutoff between immunoassay and GCMS can be variable. So GCMS is definitely more sensitive in most cases, except opioids, where it's very similar. For example, marijuana, you might detect by GCMS if the levels are low compared to immunoassay, but with opioids, it's generally about the same. Again, this is the cutoff values. You will have a copy of my handout, so this will be available to you. You may want to look at your labs and see what their cutoffs are and compare that with the federal cutoffs, because that will make a difference in terms of what is detected and what is not detected. So what are the things to consider while ordering the test? In consideration of the specimen, what is the biological half-life of the drug in question? How fast and extensively does the drug undergo biotransformation? So is it the drug or its metabolite that you want to test? And which body fluid or specimen would be best, taking into account all of this information? So getting into a little bit about the true positives, we can see in this case, this was a immunoassay which showed the urine was positive for amphetamines and cannabinoids, and the urine was positive, GCMS was positive for amphetamine. The urine was also positive for cannabis. We have a separate test which was confirmed, which I'm not showing here, but generally this is a true positive.
Hi, Avinash. This is Audrey, just giving you your 12:30 time update.
Okay, great. Thank you.
Yep.
False positives. So certain drugs can cause false positives. Medications that we commonly prescribe can cause false positives. And one of my slides has a big list, and there's a reference that you can look at. And so you have to be careful about false positives, because many of the commonly prescribed medications result in false positive, especially for the amphetamine class. Sometimes things like coca tea can give a false positive. Poppy seed muffin can give a false positive. However, with the opioids, the cutoff levels are at 2000. Poppy seed muffins shouldn't necessarily show up positive. I mean, generally it means the patient has done a little bit of research. It will take a lot of poppy seed muffin for their urine to show positive for opiates. False positives can also be because of lab errors, mixed up labels, mixed up samples. So there can be a lot of reasons for false positives. This is a table which kind of talks about all the different medications that can result in false positives. As you can see, cocaine is fairly specific. Even the urine, you can fairly rely on that for urine drug screens. It's very rare for someone to show positive for cocaine, while amphetamines, a whole range of medications that we prescribe, can show positive for cocaine. So, in false positive, a patient can be diverting the Suboxone, and they can drop a small piece of Suboxone in the urine sample, and it can test for positive for buprenorphine. So that would be an example of a false positive. Uh, False negative, it's commonly seen in those who are using cannabis. They tend to give us a dilute urine to kind of mask a positive screen. So this is an example of such a false negative. Patient's urine was positive at 79 when the creatinine level is 79 milligrams per deciliter, but it became negative when it was 15 milligrams per deciliter, and it was back positive again when they gave us a little more concentrated urine. All right, just to keep going. So some of the clinical considerations that need to be taken into account. I think it's really important to establish a provider-patient trust in this. I think helping the patient understand that this is part of a standardized set of safety measures that are in place, and therefore having a good conversation with your patient at the outset. What is the purpose of the test? What are the types of drugs that will be tested, and what are the results you're expecting? Go over the cost of the drug and review the dosage that you're prescribing and what do you expect with that dosage with the drug test. And also discuss use of other prescriptions and illicit drugs. What will happen if they used other over-the-counter or other drugs, and when it might show up positive or negative. Once you have done the test, I think it's a good conversation to ask patients what are they expecting. Sometimes they are forthright and say, hey, I use this and therefore I expect this to be positive. In my clinic, I set up an expectation of random testing. It might be worth having that conversation too if you do plan to do some random testing. And also, it's really important to kind of review actions that may be taken based on the results, so the patient has a clear understanding of what might happen with the drug test. It's important to understand that positive results indicate exposure. They are not a proof of intoxication or impairment. So there has been some exposure. Whether the patient is actually impaired or not is a completely different issue. It's also important to understand what kind of method was used. Was this an immunoassay, therefore preliminary versus a confirmatory test? It's important to understand, did the lab look at just the drug or its metabolite as well? What is the cutoff value? And if you got a negative test, is it because you're expecting a positive urine because of the medication you're prescribing and the result came back negative? So the question is, was the sample time close enough to drug exposure? Would you expect that drug to be in their system, right? And could anything interfere with the drug results? Generally be patient-centric, have a candid conversation. Most importantly, do not dismiss your patient from your care due to drug results. I think give them an opportunity to explain their results, and then discuss specific actions that you would take given that drug results, and that could involve reviewing treatment agreements and maybe changing the frequency and intensity of monitoring for those patients who have unexpected results. Finally, during the COVID period, ASAM has issued some guidelines for drug testing, given the risk of infection. Generally, in areas of community transmission, it is suggested that patients get continued access to pharmacotherapy for medication-assisted treatment without requiring patients to provide a sample for drug testing. This should be especially in situations when there is limited PPE, both for patients and staff. However, in some situations, you may be required to you may want to continue doing drug testing, and that is because the benefit of doing that drug testing is far greater than the risk of transmission, and that could involve in situations when there is known or suspected diversion, when patients have signs or symptoms of intoxication during the interaction with them, when there's concerns for overdose, and when there's a patient who's a little unstable. I think people need to have protocols in place to reduce the risk of transmission while collecting. I'm not going to go over this, but this is there in your slides. So lastly, I'm going to get into some specific testing for some drugs and alcohol that we commonly see in our practice. So first of all, alcohol. acutely, we use either blood levels or breath levels. Blood levels correlate very well with levels of intoxication, and the breath alcohol levels actually correlate very well with the blood levels. That's why we use it. The urine levels tend to be a little higher, and so for acute intoxication, we use a breathalyzer or blood alcohol levels. For chronic alcohol use, previously we were using indirect markers of alcohol use, such as elevated liver enzymes, such as GGT, AST, and ALT, and carbohydrate deficient transferase. So these were used in the past as indirect indicators for elevated indirect indicators for alcohol use. We tend to use more direct markers of alcohol use in monitoring setting these days. So you may have heard of this ETG, ethyl glucuronide. This is a breakdown product of alcohol. Less than 1%, 0.1% of ethanol is broken down to ETG and ETS, which is ethyl sulfate. Normally, most of the alcohol is broken down to acetaldehyde. But we have developed tests that are fairly sensitive to this, and so we are able to detect ETG in urine samples. So this can be utilized for drug testing. It detects alcohol exposure in the past 48 to 72 hours. Levels greater than 500 nanogram per ml are unlikely due to accidental exposure. Studies done with hand sanitizers with 20 wash per day with 60% alcohol showed levels between 10 and 114. So this may be important during this current COVID time when people may be using hand sanitizers pretty frequently. Even with mouthwash, it doesn't reach a level to show a positive level more than 500. There's a need for caution when you're interpreting in those with diabetes or with UTI, because that can produce ETG and ETS as well. PET is also known as phosphatidylethanol, is a breakdown product of ethanol again, and this is more slower breakdown product because it's something that's formed in our cell membranes, and so it can be detected up to 28 days after sobriety, and we generally use GCMS for this. The threshold is fairly high, and people are generally test positive at around 1,000 grams in 3 weeks with a daily consumption of at least 50 grams per day. So it's generally a good marker for heavy episodic to binge drinking, and it's commonly used in transplant or forensic settings these days. So the two cases that we had, the first one was a 38-year-old male with a 10-year history of alcohol use, who seems to be participating well, but the group social worker tells you that peers are reporting some alcohol use. So what would you use in this situation? The answer is ETG, because it gives you an idea of exposure in the last 48 to 72 hours. You could also do PET, but ETG is easier to do. In a 60-year-old male who's not engaging with treatment well, has given you negative drug screens, and you're more concerned about the use over a period of time, you could, in such a situation, PET is more useful. A typical test shows a positive in this manner or negative in this manner here. In this case, the ethyl glucuronide level was less than 500. Many of you in this setting are prescribing opiates for chronic pain and using Suboxone for managing opioid use disorder. So understanding opioids and opiates in your urine drug screen is critical. So I'm going to spend a little bit of time here talking about what happens with the urine drug screen with opiates. So generally, our urine drug screen, the immunoassays are able to pick up codeine and metabolites, and morphine and metabolites. Heroin is broken down to morphine through MAM, 6 MAM, and morphine is then broken down to hydromorphone and hydrocodone. oxycodone is broken down to oxymorphone. So the general urine drug screen will detect morphine and metabolites, codeine and metabolites, and will also detect heroin and it'll show up positive as urine drug screen. So they'll all show up positive as for opiates. It will not differentiate the kind of opiate that the person may be using. When you look at some of these tests, some of these other compounds like hydromorphone and oxycodone, these may actually not show positive in a routine urine drug screen. So hydrocodone is more likely to show up than hydromorphone, which is more likely to show up than oxycodone. So a person can have a negative urine drug screen despite using some oxycodone. So that's something that we need to be mindful of. None of the synthetic opioids such as fentanyl or methadone or Darvocet are going to show up in your urine drug screen. So those need to be specifically looked for through a GCMS or a confirmatory testing, any confirmatory testing that your lab is able to use. It's also important to realize that hydromorphone and oxymorphone use does not result in positive screens for hydrocodone and oxycodone respectively. So if a patient is positive for that and says that's because they use hydromorphone, it's not likely because these don't show up positive because of just the metabolic breakdown of these drugs. CDC has issued these guidelines for prescribing opiates for chronic pain that clinicians should use urine drug testing before starting an opioid therapy and consider urine drug testing at least annually to assess for prescribed medications. And then subsequent screening should be based on an individual patient basis depending on how they're doing. And when you're ordering a test, have a plan for unexpected results. How about patients in whom you're prescribing Suboxone for opioid use disorder? So Suboxone, again, is not routinely screened through standard urine drugs testing unless your lab is specifically looking for that. Immunoassays can look for Suboxones, but you need to have your labs look for that, and you may need to have an understanding with the lab that your patients will need to be tested for Suboxone. So Suboxone is buprenorphine and naloxone in a 4:1 ratio. Buprenorphine is rapidly metabolized to its metabolite norbuprenorphine and a glucuronide conjugate. So typically a urine drug screen can look for buprenorphine and norbuprenorphine because both of those are excreted in urine. Enzyme immunoassays can use this and can screen for buprenorphine and norbuprenorphine. And LCMS or GCMS is used for confirmation. Remember, Suboxone also has naloxone in it. That naloxone is not detected through immunoassay. Generally, they need to do a more standardized testing or confirmatory testing such as GCMS or LCMS. But you can utilize nor-bup to bup ratios to give you an idea if it is being metabolized or not, or if this is an addition externally. And you can also get naloxone to bup ratio to see what that looks like once Suboxone has undergone metabolism. The ratio of naloxone to bup will be very high, while nor-bup to bup will be very low if someone has taken Suboxone and the urine is testing positive the way you expect it to test positive. So this is an example of a patient who was getting prescribed Suboxone, whose urine was negative for opiates. And we did a GCMS. In this case, this is how our lab was doing it before, and their urine was positive for buprenorphine. So we have a case of a 55-year-old male who has with a history of opioid use disorder on Suboxone. He comes to you with upset stomach, says he's been on it before, he's never experienced this before in the past. Is this because of non-tolerance? So additional testing will help here, and which is what we did. So we did a urine drug screen, which was positive for opiates. In this case, it showed positive for codeine and morphine. In the past, I've had patients who tested negative for opiates, but when we did a GCMS, it was positive for fentanyl. And that kind of was the reason for that precipitated withdrawal. So this was a case of precipitated withdrawal rather than intolerance. This is a case of 43-year-old female on Suboxone, missed your last appointment in person, is somewhat somnolent, but has provided negative screening. So what could you do in this setting? So one, if you're concerned for the urine to be tampered with, you can get an observed urine sample. If the urine is negative, you could consider getting the urine for buprenorphine, which would show if they're using buprenorphine or not. And lastly, get a GCMS. So in this patient's case, what was happening was her GCMS was positive fentanyl. And after further inquiry, she admitted that she was actually dropping the Suboxone pill on the day of the test into the urine sample. And therefore, the urine was tested positive for buprenorphine. So you could be mistaken into thinking that this patient is compliant, her urine is positive for buprenorphine. So in patients who are on Suboxone, who you have high index of suspicion for misuse, get a GCMS because it'll give you a lot of additional information. Cannabis, I want to be mindful of the time, so I'll go through this quickly. Cannabis lasts in your system for a really long time, like I showed earlier, so it can show positive for a long time. Your patients, therefore, will continue to test positive even if they are abstaining from it. And sometimes people use things like Visine to give you a false negative, but dilution again can give you a false negative as well. A patient might give you a sample with a negative screen, and subsequently the urine drug screen may become positive, as in the case that I presented earlier. If they give you a urine sample with varying degree of dilution, that urine test can become negative, positive, negative, depending on the concentration of creatinine in that urine sample. So does not necessarily mean that a patient is actually using cannabis in those situations. And it is good if you have concerns to get a cannabis level. Generally, you can get a cannabis level, and it gives you that cannabis level as a ratio to the creatinine in the urine. So it factors in dilution, and you get a good idea what that level looks like. And you can use that to monitor a person's cannabis use over time if you have concerns of continued positive use. So this was the example that I talked about. In this case, this is a case of false positive. A patient was actually not using cannabis, so urine was negative. We obtained a GCMS, and the GCMS was positive for ibuprofen, which can give you a false positive for cannabis. So that explained the positive in this patient. So it's not necessarily that the patient is trying to manipulate or cheat, but the medication that you've prescribed can also result in a false positive in several situations. So this talks about, again, all the different kinds of medications that can give you false positives. Generally watching the creatinine level with cannabis, obtaining a cannabis level, and obtaining GCMS to rule out false positives. Benzodiazepines, they have a high rate of negatives. The tests are not particularly good. Even GCMS may not be confirmatory. So that's one class of medications you want to be careful about, and may have to do several tests to kind of sometimes confirm your suspicion about use. These are the resources. My slides review that. I think the SAMHSA booklet is very good. I highly recommend that. And then this article by Moeller et al., which talks about urine drug screening, which gives you really practical guidelines and some these tables with false positive. I would highly suggest getting a copy of this and reviewing this. So going back to the quiz, oxycodone will always show positive in urine drug screen. That's false. Urine with a creatinine level of 20 milligrams per deciliter is considered dilute. Alcohol use in the last 48 to 72 hours can be detected by ETG, and false positives are commonly due to prescribed medications. So in conclusion, drug testing is a tool for clinical decision making. Be familiar with the types of testing and costs of testing and the drugs on the panel. Know your lab's cutoffs. Understand the difference between the screening and confirmatory tests and associate costs with each of those. Have a clear strategy for testing and a plan for unexpected results. And be patient-centric. Educate patients about drug testing at outset and do not dismiss them from your care for an unexpected results. And so I want to acknowledge my colleagues, Dr. Park and Dr. Lawrence, for their help with this presentation. And thank you all for your attention. These are my references. I'll open it up for questions.
Thanks so much, Dr. Hasaniger. Yeah, feel free to either unmute yourself or enter a question in the chat box.
Hello?
Hi there, I can hear you.
Yeah, could you please explain the use of and how to interpret buprenorphine and norbuprenorphine ratios?
Right, okay. So I'll get back here to that slide. So generally when you ingest buprenorphine, it's going to be broken down to norbuprenorphine. And so a portion of norbuprenorphine and buprenorphine will be found in your urine. If you see a high ratio, which means there is norbuprenorphine more than the buprenorphine, that is to be is somewhat unexpected, and you will probably not see it. If your buprenorphine to norbuprenorphine ratio is very low, then it is very likely that someone may have added a buprenorphine externally, because that buprenorphine has not broken down. Let me just go back to the slide here.
Again, that's if the buprenorphine to norbuprenorphine ratio is very low.
Very low. So normally the ratio is about 0.23. Now, if you expect it in the 0.0 something range, then it's probably because the buprenorphine is too high and the norbuprenorphine. Someone could just ingest Suboxone one day before and come to you and give you a urine sample, which will show up positive. But in that case, there will not be a whole lot of norbuprenorphine that has accumulated. So again, the buprenorphine value will be much higher than the norbuprenorphine value. So if the ratio is very small, then it's more likely, and very small is so the normal is itself pretty small, which is about 0.23. But if you see in the hundredths decimal range, then you are seeing a very low level, and that could mean that they're either not consuming it or just adding it to the urine sample. So that's one. The second thing is also looking at naloxone in the sample, right? So the naloxone to buprenorphine ratio should be, again, so the naloxone is going to be pretty much not broken down, and it's not absorbed to a significant degree, while the buprenorphine is going to be broken down. So the ratio is generally high, but if the ratio is extremely high, that means the buprenorphine is and the naloxone is being added externally. So there's a whole lot of naloxone in the specimen without the buprenorphine. So again, you can get a skewed number by that. Usually your labs will be able to tell you if that looks beyond their normal range. They'll be able to tell you if there's a suspicion of some tampering with that. a lot of times your labs will give you a positive screen for both buprenorphine and norbuprenorphine in the same immunoassay. So you might think that it's just norbuprenorphine that is showing up positive, but their assay might actually be testing for both. So having a ratio is sometimes helpful in cases where you are concerned. I wouldn't do that with every case, but in cases where you have some clinical suspicion, I would look at that closely. Was I clear in my explanation?
Yes. Yes.
Great.
Hello.
Yes, I can hear you.
Okay, I have a question about the benzodiazepine. You mentioned like sometimes benzodiazepine doesn't show in the urine, like
Mhm.
for example, the short-acting clonopine and all. So what is the better test to do?
Well, I think, again, I would talk to your lab and see what kind of tests and what is their method for benzos, because there are so many, each lab has a slightly different technique and method that they use for detecting different compounds. And they'll be able to tell you how certain or uncertain any given, how certain or uncertain they are with their own testing. Generally, I find that when I suspect someone for testing, I rely on, urine drug screen. If it is showing up negative and I suspect it, I always get a GCMS. I've had patients whose urine drug screen and GCMS was negative for benzos, but they seem impaired, and a subsequent test showed up positive, and they admitted to actually using it, but their urine didn't test positive for benzos, right? So with benzos, I'm somewhat hesitant to completely go by the lab, and this is based on the labs that we send our specimen to. Your lab may have a better ability to detect benzos, so they may be able to tell you that they're more reliable compared to some other panels. So it's always a measure of that particular lab's the actual testing capability to test that particular specimen or drug, right? So you want to ask your lab how reliable is their testing for benzos. Generally, benzos is a little less than other drugs. This is from my clinical experience over the years, that my clinical suspicion is usually right in those cases, those patients usually show up positive subsequently, even if they don't show positive in that instance. So I persist with testing them over time again. Just because they were negative one time, I wouldn't, if my clinically I'm suspecting it, I would repeat that test again over time with a different sample, and if they show up, they might show up positive in those cases.
Okay, thank you.
I'm not able to see any questions that came in through comments. I don't know, Audrey, are there any other questions that you see?
Nope, no questions through the chat box. So yeah, if that's it. Thanks everyone for joining. I know I can hang out for a few minutes more if any other questions come in, but if not, thanks again.
Thank you.